see if this works. All right.
All right. Well,
crack on.
All right, mate. I'll share my screen. Just make sure. Can you guys see my presentation? So let me know if it's not coming through clearly. I might just.
Yeah, we can hear and see everything. Great.
Yeah, good. Yep. So Jebby asked me to talk on this topic, the early diagnosis of oral cancer and surgical interventions. You know, guys, I don't have a lot of insight into the way you work in PNG and you know, how much exposure you have to oral cancer. So I may have pitched this either, you know, too low or too high, but please, you know, at any point in the presentation, if you're unclear about something or if I'm telling you stuff that you already know better than me, then, you know, I'm very happy for you to just speak up. Basically, I'm an oral and maxillofacial surgeon trained in Australia, and I have a further subspecialty training in head and neck and reconstructive surgery. My head and neck exposure is my head and neck scope is mainly, you know, cancers of the mouth, cancers of the skin, and cancers of the salivary glands. But I do general maxillofacial surgery as well. So I'll just go to the next slide. So, you know, we're going to talk about early oral cavity cancer, and, you know, these pictures are obviously not early oral cavity cancer, but I guess this kind of thing is not uncommon in PNG. And, you know, by the time patients get to this point, then usually they have a very, very poor prognosis. And if they are offered treatment, then it's extremely morbid. And, you know, these patients, if they had treatment with curative intent, they'd never be able to, well, it'd be very unlikely that they'd be able to eat ever again, swallow, speak properly. And, you know, they've almost certainly got metastatic disease. And I know, especially in PNG, where resources are more limited than they are here in Australia, you know, they're unlikely to get all of the adjuvant treatment that they need, such as radiation and chemotherapy. So if you're really trying to treat this disease, you really need to pick it up early. So this is the kind of thing that you would hope to, this is the same disease, oral cavity cancer, but in its early form. And this is what, you know, you really want to try and pick up. And as dentists, you know, you guys are in a prime position to diagnose these sorts of cancers early and facilitate early treatment for these people. And if you pick these cancers up at this stage, then, you know, that they've got a good chance of survival, and the morbidity of their treatment, although it will still be quite high, obviously be much less than if they present later on. I think dentists are like the primary healthcare providers to diagnose oral cavity cancer early and make a big difference in this space. So just a bit of a brief overview. I thought I'd just quickly go over a couple of things, like what I understand as oral cavity cancer experience in New Guinea, and then some different oral cancer subtypes and subsites. And then, as I was asked to talk about early diagnosis and the treatment, I thought I'd just talk some relative points around how to make an early diagnosis and then how we treat the problem. So this is a paper that I found recently. If anyone's interested, I'm happy to share the presentation. I don't know whether you guys are familiar with this paper, but I thought it was quite interesting. Oral cancer in New Guinea is the most common cancer. Certainly in men. I think it's probably still the second commonest cancer in women behind breast cancer, but the true incidence is unknown. A lot of people obviously don't present to healthcare in PNG because of remoteness or lack of services. And interestingly, there's actually no cancer registry since 2011. So no one actually knows how much cancer is in the country. And the estimates all come from the surrounding countries that do have cancer registries. So we know that Melanesia, of which PNG is included, has the highest rate of oral cancer in the world, and it's mostly around these, modifiable risk factors. So high alcohol intake, tobacco, and betel nut. And interestingly, reading this document, it really highlights that oral health in PNG is not one of the major healthcare priorities for the government, which you guys are probably, well aware of. And I'm sure that you guys would like to have more resources than you do. There's a very large shortage of dentists, surgeons, pathologists, and radiation oncologists, and medical oncologists, and everyone else. And less than 2% of the country's GDP is actually spent on healthcare. So apparently, I don't know if this is still true or not, but in this document, which is only a couple of years old, it says that there's only one histopathology lab in the country. And I think there's only radiation therapy available in Lae, although I understand there's a new cancer centre being built in Port Moresby. So you guys really have it tough in terms of managing these patients. And if these patients with this, if these patients have any chance of a good outcome, they really need to be picked up early.
Mike,
when we talk about oral cavity cancer, yep.
Sorry to bother you. If I could just get you to turn off your video, it might help with the quality of audio and visuals.
Oh yeah, no worries. Yep.
Cheers. Thank you.
How's that? Is that coming through okay, Johan?
Much better, thank you.
Mm-hmm. So what is oral cancer? Well, again, you guys are probably already aware of this, but the oral cavity cuts off at the anterior pillar of fauces, so the palatine tonsil and the soft palate, and the posterior third of the tongue is not oral cavity. It's actually oropharynx, and it's treated completely differently. So we're going to stick to just oral cavity today. So that's hard palate forwards, retromolar trigone, gingiva, floor and mouth, and the anterior 2/3 of the tongue, buccal mucosa, and importantly, the lip as well. In Australia, most of our oral cavity cancer is in the floor and mouth and the ventral tongue and the sides of the tongue. And that's because most of our oral cavity cancer patients drink alcohol and smoke cigarettes, and the carcinogens kind of pool in that area. But you guys have a different problem in New Guinea with the buoy, and I guess people maybe hold it in the buccal mucosa. So the most common subsite for you guys is actually the buccal mucosa and the commissure. Obviously, SCC is the most common type of oral cavity cancer. And again, it's because SCC comes from the epithelium, and it's the most exposed to the carcinogens from smoking and drinking and everything else. But, it's important to recognize that there's lots of other sorts of cancers that can come up in the mouth. Salivary gland cancer is, about 3% of head and neck cancers are salivary gland cancer, but you can get sarcomas, you can get odontogenic cancers like ameloblastic carcinomas and other things as well. But I think for the sake of keeping this relevant, I'll just stick to SCC today. Now, if you want to diagnose SCC early, you need to have a bit of an idea about what it looks like. And SCC often arises de novo. So an SCC will arise in mucosa. There wasn't anything there before, and then now there's a cancer there. But there's a whole group of conditions that we call oral premalignant disorders. They used to be called precancerous conditions that can go on to develop cancer. So if you have a patient that has any of these things, erythroplakia, leukoplakia, submucous fibrosis, lichen planus, you need to be aware that these patients are at a much greater risk of developing an SCC. And if you have these patients, you need to keep them under surveillance. So not all oral SCCs arise de novo from otherwise normal appearing mucosa. So yeah, by definition, potentially malignant disorders are clinical presentations that carry a risk of cancer development in the oral cavity. Whether in a clinically definable precursor lesion or in a clinically normal oral mucosa. A lot of these pre-malignant disorders are associated with the same risk factors like smoking and areca nut and alcohol and sunlight exposure, but not all of them are. I won't go through all of them today, but you can certainly look them up, and I'm happy to talk about that at another time or point you in the right direction in terms of looking at the literature. I don't know whether oral submucous fibrosis is common in PNG. I don't think it is. It's more common in India. But certainly you'd all be aware of leukoplakia, white patches, red patches. Again, I'm not sure if lichen planus is common in PNG, but it's quite common in Australia. So just in case you're not aware, leukoplakia is just a term used to describe a white plaque in the oral cavity that can't be diagnosed as something else. So, it's not candida. It's not any of these other pre-malignant disorders. It's not lichen planus. It's just a white plaque. It can be homogeneous. It can be nodular. It can be non-homogeneous. And these white plaques, they have an increased developing CC compared to normal mucosa. Erythroplakia is the same concept, but it's a red patch. Anything with a redness in it is generally much more likely to develop cancer than a white patch. So leukoplakia, maybe up to 10% of those lesions will turn into SCC at some point, whereas erythroplakia, about 50% of them will already be carcinoma in situ, and the rest will have dysplasia in them. So up on the upper left here, this is a homogeneous leukoplakia. This would be the lowest risk of all the different types of leukoplakias to develop into SCC, but it still can, definitely. This is a non-homogeneous leukoplakia, the second one. You see it's kind of got some flat patches, some verrucous or nodular papillomatous patches. This is, and it might have some red areas in there as well. That's certainly at increased risk for developing cancer. And there may be carcinoma in situ or early cancer in there somewhere as well. And then the third one, that's erythroleukoplakia. The redness there is concerning. You would definitely want to biopsy that. And the last one is erythroplakia. Again, much higher risk of developing cancer than the homogeneous leukoplakia at the top. Now, there's another thing called oral epithelial dysplasia. Dysplasia is basically the mucosa is abnormal histologically. When you look at it under the microscope, it looks abnormal. There's genetic mutations, and the genetic mutations are causing the epithelium to mature differently. And some dysplasia will go on to form cancer. So we categorize it as mild, moderate, or severe. If the patient has, and this is a histological categorization, so you need a biopsy to determine how severe it is. If it's severe, approximately 40% of those lesions will go on to become a full-blown SCC. Whereas if it's only mild dysplasia, only about 6% will turn into SCC, and some will actually regress. So some of those pre-malignant disorders I mentioned, like leukoplakia, etc., they can be dysplastic, or they can have dysplasia components in them, but not all of them do. So the two kind of go together. So yeah, that's kind of what to look for if you're trying to really pick up a cancer early, either pre-malignant disorders or dysplasia, but remembering that quite a lot of oral cavity SCC will just arise de novo in an otherwise normal looking area. All right, now you're working in a dental clinic. How are you going to look for cancer? Well, this is actually an article that Johan put me onto a couple of weeks ago when we were running a oral cancer screening kind of course here in Australia. But it's a kind of a nice walkthrough if anyone wants to take a note of that paper. And again, I can pass that information on later. But basically, and I'm sure you guys have been taught this, but oral SCC metastasize, if it's going to metastasize, it will metastasize via the lymphatic system most of the time, and it's generally stepwise through the lymph nodes. So it'll go to the submental and submandibular lymph nodes and then down the jugular chain. So when you see a patient, you want to palpate the neck, palpate all of the lymph node groups that could be involved, and then you want to have a really thorough look through the oral cavity, starting with the lips and the vestibule, the gingiva, and then the buccal mucosa, tongue, etc. There's no like definite right or wrong way to do this, as long as you look at all of the mucosa, because oral SCC can grow from any of the epithelial lined areas of the mouth, from the attached gingiva to the floor of mouth to buccal mucosa, and to the vermilion of the lip. Now, just a couple of points to note. You need to remove the dentures. Obviously, if the patient's wearing dentures, you want to take everything out of their mouth. If you're not sure about something, I think a good rule of thumb is if you think something looks a bit funny, there's a bit of an ulceration or a white patch, and you're not sure, it could be that the patient had a sharp tooth or ill-fitting denture, or they might have bit their tongue, or they might have some local trauma or whatever. If you're not sure, then a good rule of thumb is to just try and remove that aggravating factor and then re-review the patient in 2 weeks. If it's still there in 2 weeks, then you should really be looking to either biopsy the lesion or send it to someone who can biopsy the lesion. And, as primary healthcare providers, you guys are really in the best position to counsel these people that don't have cancer, but high-risk patients that are, using a lot of betel nut and smoking and drinking, that, you need to educate them about the risks and educate them about what they can look out for as well. Now, I'm not really big into this, but I thought I'd mention it just for completeness. There are some examination adjuncts that you'll see in the literature if you look into it, that can potentially help primary healthcare providers detect suspicious lesions above and beyond what you would normally just do. So normally the patient comes in, you're going to look in their mouth, you're going to feel around, you're going to feel their neck. That's generally all you can do. Apart from biopsy. But there are some adjuncts, like there's this blue dye called toluidine blue that's acidophilic, and there's more acid in cancer because there's more DNA, because the thing's replicating quickly. DNA is acidic, and the blue stuff will stick to the cancer more than normal mucosa. There's all this fancy kind of imaging, narrowband imaging and stuff, but it's not really used much in Australia, and I presume it's not really used much in New Guinea. And the evidence does not support all of these kind of adjuncts in terms of diagnosing cancer early. Really, all it kind of does is help primary healthcare providers refer lesions quicker. But if you know what you're looking for and you're sensible, then you're going to refer appropriately in the right time fashion anyway. Just a little bit about imaging. So again, I'm not sure how much, from a resource perspective, how much of this sort of stuff you have good access to. I'm sure you all have OPGs and dental imaging, but with cancer, it's kind of gold standard to utilize some of these other imaging modalities like CT, MRI, and PET scans. So I would never treat a cancer in Australia, an oral cavity cancer, even if it was the smallest little 3 millimeter cancer, without a CT of the head and neck, some sort of imaging of the chest, which is usually a CT scan of the chest as well. Occasionally we use MRI. MRI is fantastic for looking at nerve. So SCC sometimes likes to grow along nerves, what we call perineural invasion. And if you're worried about perineural invasion, an MRI is fantastic for picking that up. And an MRI is also really good at looking at soft tissue. So if you've got a tumor in the tongue, for example, you can get a really good idea of the depth of the tumor on MRI, whereas you might not get that with a CT. And then we use a PET imaging as well, positron emission tomography, which is like a functional imaging. Basically, you inject the patient with sugar, and the sugar has got a radioactive molecule attached to it. And parts of the body that have a high metabolism that are using a lot of sugar, a lot of the injected material will be taken up in that area. And then you scan the patient with, like a method that picks up the radiation. And so this is an example of that sort of scan here. The patient's got something going on. This is their larynx here. And you can see over in the neck here, there's a large lymph node, and the lymph node's lighting up. There's a lot of metabolism in this area. And that could really, in this situation, only be explained by cancer. But, for example, the brain lights up because the brain's very metabolically active. The heart, the bladder fills with the material because the patient metabolizes it through the renal system. So you can't use it in every organ, but it's fantastic in the head and neck area. So we often use PET scan as well. And if you've got a patient with an oral cavity cancer and you think, it's fairly advanced, I wonder if they have any distant disease in the lungs or their bones, for example, because if they did, then we wouldn't offer them curative treatment. Then you do a PET scan and it could show you, if it shows you that there's something lighting up in the lung, then you wouldn't put them through the morbid operation and the radiation and everything because they can't be cured. So they're the kind of three more common imaging modalities that we use. Ultrasound, which I'm sure you're all familiar with, it's just kind of like sound waves. There's no radiation. We use it in the setting where someone has a lump in the neck or in the parotid gland, and we want to do a biopsy of that with a needle. We stick a needle into the lump and, aspirate or suck out some cells, and we can use the ultrasound to show us that the needle's going into the lump. So this is the needle here advancing, and this black thing here is the lump. That's a brief rundown on imaging in head and neck cancer. Now, this is something that, again, you guys maybe already know, but if you don't, then I think this is probably pretty relevant. The only way to diagnose cancer in the oral cavity is with a biopsy. So you need to have histological proof that's a cancer. You can't tell, it's pretty obvious sometimes, but you can't always tell just by looking at things. Now, the recommended type of biopsy in the mouth is an incisional biopsy. So if you see an ulcer on the tongue or the gingival palate, you should, and you're going to biopsy it, it should be an incisional biopsy. You don't take the whole lesion. It should be a deep biopsy. And it's generally good practice to include the margin of the lesion so the pathologist can compare the normal surrounding tissue to the main lesion. The reason it should be deep is because one of the key kind of determinants of how we treat these things is the depth or the thickness of the tumor. So if you just skim the surface, we don't know how deep it is, and then that may affect the way that the patient has their ultimate curative treatment. It's not good to do an excisional biopsy, particularly if there's going to be a gap in the patient's treatment journey from biopsy to the definitive treatment, because then you won't know where the lesion is, and it's hard to then resect the appropriate area. So, for example, I've treated a few cancers in the last few weeks that had their biopsies done in a rural setting about 4 hours away, and the surgeon down in the area did excisional biopsies, and then when the patient turned up to have their definitive treatment with us, there was just a scar. But of course, there'll still be malignant cells in the region, and the patient then gets suboptimal treatment. So just again, one more time, just in case, incisional biopsy is the gold standard if you're concerned about a lesion in the mouth being cancer. There are other types of biopsies as well. For example, fine needle aspiration, so that should say FNA, and core biopsy. That's more when we're biopsying, things in the parotid or the neck. Does anyone have any questions so far? Okay. This is a brush biopsy. Again, just for completeness, I never use this, and I don't think you guys would either, but it's kind of like what some primary healthcare providers can do to look for malignancy if they're not sure. If they're not sure how to do a proper incisional biopsy, it doesn't really cause any pain or trauma. It's kind of like a pap smear. So you just rub the brush over the lesion and it theoretically picks up malignant cells. And then a cytopathologist needs to look at the slide and look for evidence of malignancy. But you need a very specialized service and specialized pathologist to look at that and to interpret that. And then even if it comes back as being suspicious for cancer, you still need to go and do a proper biopsy. So just so you guys know for completeness that brush biopsies are sometimes used in the oral cavity, but not really in our centre. Now, if you've got a patient that you've taken a biopsy for and it's come back as cancer, the next thing you need to do is stage them. So you need to determine what is their overall treatment stage, because that will determine the treatment they receive. And there's three things that we look at. We look at the primary tumour, the tumour in their mouth, then we consider the lymph nodes in the neck, and then we consider whether there's any spread to the rest of the body. And the gold standard for staging at the moment is the AJCC, which is currently in its 8th edition. For oral cavity, these are the things that this is the information we need to tell us how to stage the primary tumour. So for example, I mentioned to you about depth before, the depth of the tumour on the incisional biopsy. You can see that if a tumour is less than 5 millimetres in depth, it's a T1. If it's 5 to 10 millimetres in depth, it's a T2. If it's more than 10 millimetres in depth, it's a T3. So it's not just the size of the lesion in terms of its cross-sectional surface area, the depth is very important as well. And then, as I said, we then look at the nodes in neck. And the things we want to know: how big is the node? Is there multiple nodes or single nodes? Are they bilateral or contralateral? And this E&E is extranodal extension. It has a profound effect on the patient's prognosis and the treatment they receive. Basically, if there's disease that's spread in the lymphatics to a lymph node, the lymph node has tried to contain the disease, but it couldn't hold on anymore, and the disease is sort of perforated through the capsule of the lymph node into the surrounding tissue of the neck. That's what we call extranodal extension. In some papers, you'll see it written as extracapsular spread. That's a very bad prognostic factor for the patient. And then finally, do they have any distant disease? They either do or they don't. And if they do, they're not curable. Now, technically, Jebby asked me to talk about early stage oral cancer. We consider early stage to be these two things here. So the patient has no disease in the neck, they have no disease anywhere else in their body, and they have a relatively small tumour in their mouth. That's what we consider to be early stage, technically. Once the patient's staged, if they're well enough to be treated with curative intent, then we will plan their treatment. Now, oral cavity cancer, as it says there, is a surgical disease. We treat anyone that's going to have their oral cavity cancer cured is treated with surgery as the primary mode. Sometimes patients with laryngeal cancer or oropharyngeal cancer will be treated with primary radiation or chemoradiation, and they'll do better than if they had surgery, but it is not the case for the mouth. After we've cut out the cancer, we sometimes give the patient post-operative radiation therapy, post-operative chemotherapy, but rarely do they get that before the surgery. The surgery is usually the first line. And then the oral cavity SCC, we generally remove the tumour with a macroscopic margin of 1 to 1.5 centimetres. So you can see in the picture on the top here, the central kind of purple circle, someone's outlined the tumour. And then you go and measure with a ruler 1 to 1.5 centimetres beyond that. And then that's your margin. You need to take that macroscopic margin of 1 to 1.5 centimetres. And that's in all three planes. So you need to make sure you take a 1 to 1.5 centimetre margin depth-wise as well when you're removing the tumour. And then once the tumour comes out, it goes to the pathologist, and the pathologist looks at it under the microscope. And what you're aiming for is that the tumor cells that are closest to the margin are still at least 5 centimeters away from the margin. And we call that clear margins, which is very good from a prognostic factor. If there's cancer cells within 1 millimeter of the margin, we say the margin's involved and it's suboptimal, and you need to consider going back and taking more tissue. Sometimes we use frozen sections, but very rarely. So basically we cut the tumor out, and if we're not sure, you can cut a little bit of extra tissue in an area you're not sure about, and the pathologist can look at that on the spot for you, but it doesn't tend to work very well, and it doesn't have good evidence. Now, the 1 to 1.5 centimeter margin, that stands even if, so everything in that radius needs to come out, regardless of whether it's a nerve, a salivary duct, a tooth, jawbone, anything within that margin needs to go. Now, different sites in the oral cavity, we have different considerations for. Firstly, we need to think, how can we get access to this site to safely remove this tumor? And then we need to think about, how we're going to put the patient back together again after we've taken the tumor out. So there's a few different types of approaches that we utilize for the oral cavity. Most of the time for small tumors, you can probably get it out with just a transoral approach, so open their mouth and cut it out. But sometimes you can't. So I'll just go through a couple of other access procedures that we often utilize. Okay, so first of all, transoral, you can see here, this is buccal mucosa. If they had a little tumor here, then, obviously you don't need to do anything crazy. You can just open their mouth and cut it out. Same for the side of the tongue and the floor of the mouth. If they have a tumor in the buccal mucosa and it's all the way back towards the retromolar trigone, you may find, and the patient may have limited mouth opening or a big fat tongue, you may find that your access is not good and you can't safely get those margins that you need by going transoral. Then what we sometimes do in that setting is split the lip and flip this cheek out just like this. So you see this is the cheek, it's been just, they've had the neck cut and then the cheek lifted up, and then we can easily access the buccal mucosa and make sure that we get an appropriate surgical margin. And similarly, we can go through the upper lip. This is called a Weber-Ferguson incision, and that will help us get to the back of the maxilla if we can't reliably get around the back. Say you had a tumor of the, maxillary tuberosity or something like that. There's something called a mandibulotomy. So if you have a patient with a tumor on the back of their tongue, sometimes it's very difficult to get to the back of it and get an adequate margin around the back if you just try and go through their open mouth. So sometimes we split the jaw, it's called a mandibulotomy, and then we can make a cut in the floor of the mouth and pull the jaw apart, and then we can easily get to that area. And then at the end, once we've put the tongue back together, we put the jaw back together, plate it back together, and stitch everything up. So you can see here, this patient's got 2 plates on their jaw. The jaw would have been split here, and it's been put back together, and the tongue's been resected. And this is actually skin, and it's probably from their thigh. We often reconstruct tongue defects like this with tissue from the thigh or the forearm, and then you put the lip back together again. Now, if the tumor is on the gingiva or in the floor of the mouth but abutting the mandible, as I said, you need to take anything within that 1 to 1.5 centimeter margin. If the tumor is in the gingiva but on that CT scan or MRI, it doesn't appear that there's any obvious erosion of bone, then we will do a marginal mandibulectomy. So we take a piece of bone away, but we don't need to completely take a segment out. If there's any suggestion that there's erosion of cancer into the medulla of the mandible, we take an entire segment. That obviously has implications when you're reconstructing the patient. And then finally, not usually utilized for small tumors, but as an alternative to the mandibulotomy, where you cut the mandible and open it up, you can do a lingual release, particularly for tumors on the back of the tongue. So in this situation, you basically just make an incision all the way around the ridge the crest and separate all of the floor of mouth from the mandible, and then you can pull the tongue through the neck. And then once you've cut out the tumor and reconstructed it, you can put the tongue and the floor of mouth and everything back up there and suture it back in place. So that's the primary site. Then once we've made our plan for resecting our tumor in the mouth, we think the next thing we need to think about is the neck. Now, as I said, most SCCs, well, all SCCs in the oral cavity, if they're going to spread, it'll usually be to lymph nodes in the neck. But what if you have a patient that has a fairly small tumor and you can't feel any nodes in the neck, and a CT and an MRI and you can't see any lymph nodes in the neck? Well, it doesn't mean that there's no disease in the neck. Those imaging modalities are only about 60 or 70% sensitive for patients that have microscopic disease. So if the patient's got microscopic disease in the lymph nodes, the only way you'll know is if you remove the lymph nodes and examine them. So as a general rule, if the cancer's in the mouth, if it's more than about 3 to 4 millimeters in depth, then we will elect to do what we call an elective neck dissection. So we remove the lymph nodes from the neck as a staging procedure to see if there's any cancer in the lymph nodes. The neck is also relevant when we're thinking about reconstructing the patient, because we can use blood vessels in the neck and tissue from the neck or the chest to reconstruct the defect in the mouth as well. I probably won't mention sentinel lymph node biopsy unless anyone particularly wants me to. And there's lots of different types of neck dissections. If the patient's got a lot of disease in their neck, then they may need what we call a radical neck dissection. And that's where we remove the lymph nodes from all 5 levels of the neck, as well as the sternocleidomastoid, the internal jugular vein, and the accessory nerve. If the patient doesn't have any disease in their neck that we know of and we're doing an elective neck dissection, then we'll often just remove a select number of spaces where we think it's most likely that the tumor will spread to. And we'll try and preserve all the neurovascular structures to minimize morbidity. All right, so we've removed the tumor from the mouth and we've either performed a neck dissection or not performed a neck dissection, depending on what we thought the risk of metastases to the neck was. The next thing we need to think about is how we're going to put this patient back together again. If we've removed a tumor from the palate and it's involved the soft palate, then they're potentially going to have speech issues and swallowing issues. If we've removed the lesion from the side of the tongue or the floor of the mouth, and their tongue can often get tethered down and they have reduced tongue mobility, or they may have a communication through down into the neck because we've removed the floor of the mouth. So we need to seal the mouth from the neck. Or we may have, removed a part of their maxilla and they have a oronasal or oroantral communication and we want to block that off. So we need to think how we're going to put the patient back together again. And there's a whole heap of different ways to do that. And basically, it depends on your resources. It depends on how fit the patient is. It depends on patient preferences, what's important to them. It depends on what you're trained to do. So there's a whole heap of different ways you can put people back together. It could be as simple as chopping the cancer out and stitching the wound together again. You might use a skin graft. You might use a prosthetic obturator, or you might do something really fancy like a free flap, which is where we basically harvest tissue from another part of the patient's body, whether it be the leg or the shoulder blade or the hip, forearm, and we transplant it to the head and neck region with a microscope and microsurgical techniques. So just as an example, on the top here, the patient's had a partial maxillectomy, and you can see they've got an oronasal communication. You can see the inferior turbinate up there. And the patient wasn't up for well, this is not my patient, this is from Google, but the patient must have either not elected for or wasn't fit for, or the surgeon wasn't capable of doing a tissue-based reconstruction. And a nice simple way to reconstruct this patient is just to make them an obturator, which you guys may or may not have made. It's kind of just like a partial denture, but it's got a bulb on it that extends up into these holes to block them off. Good thing about the obturator, it's cheap, it's quick, facilitates a quick discharge from hospital. It's effective as long as there's adequate teeth remaining to retain the thing. If you took all these teeth out, then there's no way you can retain an obturator. Or if the maxillectomy went right up into the orbit, then the obturator is not going to do very well in that situation either. And, there's other things you can do if you don't have any teeth. This patient's had a total lower level maxillectomy. You can see that bilateral sinuses in the nasal cavity. You can put dental implants or zygomatic implants in and have an implant-supported obturator that achieves the same result as this. But if the patient didn't want to use a prosthesis and they wanted to be reconstructed to as close to what they used to be as possible, then you might consider transplanting bone and soft tissue into the area and then dental implants into that bone so that they didn't have to worry about taking this thing in and out every day. Johan, that's kind of the basics of oral cavity that I kind of wanted to talk about. And then I just have some information on free flaps if the guys would kind of had any particular interest in that. But what do you think?
Yeah, thanks, Mike. We might ask the attendees what they think, if they have any questions so far. Does anybody have any questions particularly?
Mic test.
Yeah, Jebby, we can hear you.
Oh yeah, so just one question. What are the consequences of not taking out the appropriate margin? Does it pose a risk for reoccurrence for the cancer?
Yeah, great question, Jebby. So yeah, if you have an involved margin, so if there's tumor all the way to the edges of your resected specimen, then the presumption is that there is still cancer there, and you would expect a fairly rapid progression of the disease. So the tumor will come back in the local area, and it's every day that it's still there, it's got a chance of spreading to the regional lymph nodes and beyond. If you have a close margin, then we know from longitudinal studies that patients with close margins are more likely to get both local recurrences and regional recurrences. So they may not get a cancer back in their mouth, but they might pop a lymph node up in their neck, or they may get a cancer back in the mouth again. So if it comes back in the same site, we call it a local recurrence. If it comes back in the neck, we call it a regional recurrence. And yeah, we know that patients that have close margins and definitely involved margins are much more likely to get local and regional recurrences.
Right, thanks.
Mike, just on that as well, to follow up from Jebby's question. Obviously, in the low resource setting, getting a full margin safely, it may not be an option. But I suppose in your experience, has taking parts of a tumor helped in the quality of life or palliative care for certain patients? Is it worthwhile in some cases taking off part of the tumor, even though you know there's going to be rapid progression of disease?
Yeah, if you're not aiming to get clear margins, then you're essentially, it's a compromised treatment, and it would be, not considered curative treatment or treatment with curative intent. And there's definitely times where that may be appropriate. Having a great big fungating, ulcer that's eroding through your face, they smell really bad, they bleed, they cause a lot of pain. So in certain situations, it could be obstructing their airway. It's so big, it's growing at the back of their mouth. So in certain situations where the patient's, not going to be cured, you still may elect to provide them with some sort of suboptimal resection to relieve their symptoms. But in saying that, given that the topic of this talk is early oral cavity cancer, most patients with early oral cavity cancer can be cured and will be cured if they have, ideal treatment, which is the most important thing, is adequate resection. So certainly not everyone with early cancer will survive. I've seen lots of people with not lots. I've seen a few patients that have had very small cancers and they've just unfortunately had aggressive disease biology and they've died. That's the other thing that I should say. Not every SCC is the same. Not every, you could get two patients, they're both 30 years of age, they've both got a 1 centimeter SCC on their tongue. They're both fit and healthy patients. Those tumours will not necessarily behave in the same way. Every tumour has kind of different biology. Some of them grow along nerves and blood vessels and are very aggressive and spread early. Some of them will sit there for 1.5 years and not metastasize. So they all behave differently. But if you're just treating the disease as a concept, we usually aim for a clear margin if we're treating it with curative intent.
Thanks, Mike. There's another question in the chat from WH. Can chemo be used first to reduce the size of tumor followed by surgery, and particularly in reference to the oral cavity?
Oh yeah, it can be. It can be, particularly if you think the tumor is probably unresectable or borderline unresectable. I didn't go into it, but in the staging part, when I mentioned the primary tumor staging, T4B is considered unresectable disease. And for oral cavity, that will be when it's gone from the buccal cavity up into the infratemporal fossa, or where it's wrapping around the internal carotid. And in certain situations, if you give the patient upfront chemotherapy, or what we call neoadjuvant chemotherapy, sometimes it can turn an unresectable cancer into a resectable cancer. So that's certainly utilized in some settings, and it is being utilized more with the introduction of immunotherapy, which I didn't touch on, but immunotherapy is kind of like a new class of, it's not really chemotherapy, but it's a systemic therapy that works in a different way. And some centers are starting to use upfront combinations of upfront chemo and immuno before they offer surgery for borderline resectable oral cavity cases.
I suppose that's more to do with those late stage.
Yeah, and I don't think it's not like common,
No.
and it's not like,
Probably
it's
not
only really done in super specialized centers, and I don't think it's like it wouldn't be something that you'd see in PNG or even Australia for that matter. Yeah.
Actually, on the topic of what's available in PNG, I thought I might ask Jebby or Bradley to comment on what access do you guys have to imaging there in Port Moresby, in terms of, if you wanted to, could you order a CT of the head and neck, PET CT or MRI, or would you have to refer that to one of the physicians in the hospital?
For that, I'll let Bradley or Kennedy or Dr. Posolok, if you guys could stress on that. Thank you.
Hi, it's Posolok here. The usual method that is done is that most of the patients are referred to the OMF team, and then the OMF team then liaise with the radiography department, and then that's when they do the test from there. But as for general dentists and other students, I think the standard procedure is we just refer the patient to the OMF team, and then they then manage from there.
Yeah. It's really interesting in Australia now. So I don't know, do you guys have a cone beam CT, or are you familiar with cone beam CTs? Basically, it provides you with a 3-dimensional image. It's very similar to your conventional CT scan, but they're smaller units, and they can actually be fitted to dental clinics like, your regular run-of-the-mill private dental clinics. And in Australia now, a lot of private dental clinics, general dental clinics, will have these cone beam CTs in them. So general dentists are now utilizing CT scans in Australia for, assessing the morphology of root canals, assessing, third molars for proximity to inferior alveolar nerves, for implant planning and that sort of thing. This sort of technology is super accessible now here, but I presume it's not readily available to you guys. It's a bit of a luxury. Johan, there's another question here from Kennedy about the obturator. Can I just ask, do any of you guys have experience in making obturators?
Hello, Kennedy here. I haven't seen anybody doing an obturator here, so I'm curious about this one. So I'm just asking this question. Thank you so much.
Yeah. Hi. Okay. No worries, Kennedy. Yeah. Look, the obturator is, it's pretty similar to making an acrylic denture. So it's definitely within the realm of a general dentist. Certainly prosthodontists and maxillofacial prosthodontists. It's sort of not very common here anymore because we have such good access to resources and we can reconstruct these patients with free flaps and those sorts of things. But like I said, it's a really good option in certain patients for a couple of reasons. One is that it's quick. Two is that it's cheap. And it's adjustable. And the other good thing is that you can easily remove it and perform surveillance on the site where they had their cancer to make sure they don't have any signs of recurrence. Whereas if you put a big free flap in there, it's a bit hard to see what's going on underneath your free flap. Now, the way that we kind of decide who can have an obturator and who wouldn't do well with one is that there's lots of different classifications for maxillectomy defects, but there's two that are really good. One is by an author called OK, which is OKAY. He's a prosthodontist. And the other is James Brown. It's the Brown classification of maxillectomies. And basically, it depends on how many teeth you have left, whether you're going to have adequate retention from the teeth. And it depends how high up the maxillectomy goes. But complications-wise, it's just like any other removable denture. There's going to be increased wear and tear on the remaining teeth. The patient will get soft tissue irritation if they don't take it out and clean it very often. When these people take these things out of their mouth, there's like a big flood of mucus that comes out when they take it out, because all of this mucus from their nose and their sinus just sits on top of the obturator. When they take it out, it all falls out. So maybe they're a bit socially unpleasant from that perspective, but there's not really otherwise too many complications. It's just, can they comfortably wear it, and will it adequately seal the mouth from the nose and the sinus? They're a pretty good option if you've got a fairly small maxillectomy that's low level. Yeah. Does that answer the question?
Yeah, it's very, very clear now. Thank you very much.
No problem.
Cheers, Mike. We might have to get Salah to do a lecture on obturators or something.
Yeah, you should. For these guys, I think it's an excellent feather in their cap, so to speak. It's not very nice to be walking around with a defect like that in your mouth. And it's great that your cancer's gone, but sometimes we leave these patients with a lot of morbidity and we pat ourselves on the back that their cancer's gone, but they have a markedly reduced quality of life, and making essentially a removable denture can have a profound effect on their cosmesis, their lip support, and their function. If they've got a hole in the roof of their mouth, they're going to have really weird hypernasal speech. Every time they eat and drink, food's going to come out their nose. So it's something simple, and it's something these guys can definitely do. So yeah, I think it's a good one.
Any more questions from the audience.
Cool. Should we leave it at that?
Yeah,
Johan, happy with that?
that was great. Thanks, Mike. We had about 16 participants. A few of them had to come in and leave us, but in terms of UPNG, I think that is the equivalent of one cohort, Mike. So
Yep.
Great job. Thank you so much for dedicating your Saturday evening.
Yep.
Jamie?
No worries at all. And listen, I'm happy to share the presentation. However, the best way to do that is if anyone would find it useful, and I'm happy for you to share my contact details. If anyone wants to send me an email, that's fine.
Thanks, Mike. I might get you to email the link with me and Diane in that email, and they can forward it on.
Yeah, no worries.
Jebby, did you want to make any comments before we wrap up?
Yes. Well, first of all, thank you very much, Dr. Hurrell, for your time and for the presentation. I believe we all at least learned something from this. Yeah, we're looking forward to having more lectures with you. This is a groundbreaking lecture. We're sorry, it's unfortunate we were supposed to book a venue, but like I said, we couldn't do that here. So yeah, I think we should we could have lectures like this via Zoom until the school or our admin here allows us to use one of the lecture halls. Yeah. But otherwise, thank you so much for the lecture and your time, Dr. Hurrell.
Yeah, no, you're welcome. No worries at all. And yeah, happy for any feedback. If I missed something or there was something you wanted me to clarify, then as I said, let me know.
Thank you.
Thank you.
Okay, good on you guys. Enjoy your weekend.
You too. Cheers.